Welcome, ladies and gentlemen, to this new video. It is my pleasure to present to you an artificial assisted abdominoperineal rectal resection with a near total posterior colpectomy performed for rectal cancer at 15 centimeters from the anal verge with a solitary metastasis of the distal rectovaginal septum. A right-sided VRAM flap was utilized to reconstruct the posterior vaginal wall, as well as close the perineal defect. I will be discussing the case in detail and showing all stages of the procedure while pointing out some tips and tricks as well as possible pitfalls. So this is an 89-year-old lady who presented with discomfort in the perineal region and was primarily examined by the gynecologist. A palpable mass was detected at the level of the rima perinae during bidigital examination, clearly infiltrating the vaginal mucosa. A fine needle biopsy revealed surprisingly cancer of colorectal origin. Colonoscopy and MRI imaging revealed rectal cancer at 15 centimeters from the anal verge. The above-mentioned mass in the rectovaginal septum was interpreted as a metastasis of the rectal cancer. CT imaging did not reveal any further metastases. A minimally invasive abdominoperineal rectal resection with a near-total posterior colpectomy was recommended by the MDT. Due to the high age of the otherwise healthy patient, it was decided to perform a two-stage procedure. In the first stage, the resection was performed. The second stage, performed 2 days later, involved reconstruction of the posterior vaginal wall and closure of the perineal defect using a right-sided VRAM flap. Our colorectal unit has gained experience over the years in this technique, and we perform the perineal defect closures as well as vaginal wall reconstructions with a VRAM flap ourselves whenever needed. The patient had an uneventful post-operative course after both procedures and was discharged on day 12 after second surgery. Pathology revealed clear margins. The remaining details are available on this slide. This MRI sequence demonstrates the locations of both the primary tumor and the metastasis. Trocar placement and the intraoperative setting are shown on this slide. As you might expect, and if you have watched previous low anterior resections or left-sided colectomies on my channel, I always try to start the medial to lateral approach by exposing and dividing the inferior mesenteric vein. This is relatively easy to do and provides a good guide to join the planes later when performing the TME. Moreover, and in case a colorectal anastomosis is going to be fashioned, which is not the case here, division of the inferior mesenteric vein just below the lower pancreatic border has been shown to provide additional colonic length to perform a tension-free anastomosis. This can be a tricky task sometimes, especially when the small bowel is blocking your vision, but you can see how articulation provides here an amazing advantage in terms of accessibility and dexterity. Medial to lateral dissection between the garrota fascia and the mesocolon is continued at this stage as far as it can go. The mesorectal plane is accessed and the cranial part of the TME is started. The hypogastric nerve is visualized and preserved. You can now appreciate the advantage of having performed the dissection previously at the level of the inferior mesenteric vein, since once you now join the planes, the inferior mesenteric artery can be exposed with relative ease. To make full advantage of articulation at this step, I go with the articential forceps behind the inferior mesenteric artery and perform traction in the ventral direction, making it easier to expose the artery with the articential scissors. Taking care to exert enough traction and counter-traction, medial to lateral dissection is largely performed until the lateral abdominal wall is reached. The lateral adhesions are divided in this case from the medial approach. The mesorectal plane can be very nicely observed here after providing enough traction. The left ureter is being continuously checked and preserved. If you have the chance to divide the lateral adhesions from the medial approach, I recommend to do this, since you will appreciate this later once you turn to lateral dissection. This will definitely make your task much easier and spare a lot of operative time. Some pelvic adhesions that formed after a previous hysterectomy are divided. Since we're performing an APR and no anastomosis is being fashioned, there is no reason to take down the splenic flexure. Lateral dissection is halted at this point. The colon is then skeletonized at the designated level of transection. I decided not to use a vessel sealing energy device in this case just to perform this short task. Instead, the mesocolon is divided by alternating the use of the artisential bipolar forceps and the artisential monopolar scissors. This technique is a bit slower than when using a vessel sealer, but it does the job effectively. Indocyanine green enhanced fluorescence angiography is performed to check for bowel perfusion before transecting the descending colon. A terminal colostomy is fashioned, which is not shown in this video. TME is continued along the previously accessed plane. Once the TME is finished and maximal circular dissection until the levator muscle has been performed, we turn to the perineal side to complete the excision. After putting in a purse string suture around the anal region, the excision line is marked, taking care to keep a sufficient resection margin to the palpable mass in the rectovaginal septum. Excision is performed with a monopolar electric scalpel, always keeping in mind that a near-total posterior colpectomy is part of the en-bloc specimen. The pelvis is accessed posteriorly through the levator muscle. The levator muscle is then gradually divided laterally up to the vaginal pillars. Once the skin at the posterior vulvar area on each side has been incised, excision of the posterior vaginal wall is performed on each side using a ligature device. Also here, care is taken to keep a sufficient resection margin of at least 7 mm to the palpable mass in the rectovaginal septum. Once the vaginal apex is reached and a sufficient cranial resection margin from the palpable mass is achieved, the posterior colpectomy is completed and the en-bloc specimen is retrieved. The en-bloc specimen, including the TME and the posterior vaginal wall, is appreciated. Hemostasis is performed and the perineal defect is draped. Vaginal wall reconstruction and closure of the perineal defect are scheduled to be performed after 48 hours. The 89-year-old patient was extubated and was doing excellent following the first procedure. The perineal as well as the vaginal defects are appreciated 2 days later before reconstruction with a VRAM flap. The right-sided VRAM flap is marked. The colostomy site is covered with a gauze dressing and an adhesive film. Care is taken to cut down through the subcutaneous tissue in a strict perpendicular direction to avoid excavations. Once the fascia is reached, subcutaneous tissue is dissected around 5 to 10 millimeters lateral to the linea alba. This allows for a short edge on the medial side of the rectus sheath to remain intact once the rectus space is accessed. This is important to enable closure of the rectus space at a later stage of the procedure. The rectus abdominis muscle is carefully dissected off the posterior rectus sheath. Division of the rectus abdominis muscle, together with the superior epigastric vessels, is performed at the subcostal region. The rectus abdominis muscle is further mobilized and lifted off the posterior rectus sheath. Skin incision is continued along the marked line on the lateral side of the future flap. Also on the lateral side, Care is taken to leave a small edge of the lateral part of the anterior rectus sheath intact to enable closure at a later stage of the procedure. The final steps of mobilizing the rectus abdominis muscle are performed in a meticulous manner so as not to inadvertently injure the inferior epigastric vessels, which provide the entire perfusion of our flap. Finally, the distal and the last remaining part of the anterior rectus sheath is horizontally incised ventral to the distal part of the rectus abdominis muscle to provide more mobility and prevent tension. It is also generally possible to divide the distal part of the rectus abdominis muscle just ventrally to the inferior epigastric vessels, which would provide maximal mobility, since the only remaining attachment of the flap would be to the inferior epigastric vessels. This was not needed in this case, and I decided to leave the distal part of the muscle intact. Next, a small longitudinal incision is made distally at the posterior rectus sheath and the peritoneum to enable the pull-through of the flap. The flap is then rotated 180 degrees clockwise and it is introduced into the abdomen. A transperineal pull-through is then performed. Care is taken not to exert tension on the root of the flap. ICG-enhanced fluorescence angiography is then performed to ensure an excellent perfusion of the flap after the pull-through maneuver. The flap is then marked so that the skin section would suit the required area needed to reconstruct the posterior vaginal wall as well as the perineal defect. After that, the flap is taken out of the abdomen and is then de-epithelialized along the marking lines. The flap is then reintroduced into the abdomen in the same manner and a transperineal pull-through is performed. The flap is fixed in its position to avoid dislocation and eventually tension. Abdominal closure is then performed with a 2-0 PDS running suture at the level of the posterior rectus sheath. The medial and lateral edges of the anterior rectus sheath are also brought together and closure is performed with a 2-0 PDS running suture. A few subcutaneous interrupted vicral sutures are made. Intravaginal fixation of the flap is performed with 3-0 vicral interrupted sutures. Care is taken to ensure an exact intravaginal adaptation of the flap to reconstruct the vaginal canal. The extravaginal interrupted skin sutures are performed with 3-0 ethylon. The final result of our reconstruction is appreciated. ICG-enhanced fluorescence is performed at the end of the procedure to ensure adequate perfusion of the final result. The patient was discharged on day 12 after a second surgery and had an uneventful postoperative course. Pathology revealed clear resection margins. Please don't forget to subscribe to my channel so you can be informed about future videos. If you liked watching this procedure or you have any suggestions or recommendations, make sure to leave a comment. Thanks for watching.